Of course, is well known for being a critic, but also holding a mirror up to us in what we do, and then having a dialogue with us on how we can do it better. So, Ben, the task in the next quarter of an hour is to ask you, why do you think that the current clinical trials are not working? And in your experience, is there a better way of doing it? Over to you.
Well, thanks, and thanks for asking me to come. And I think, as you said, I think I'm probably your sanest critic. And I write about problems in all kinds of different spheres, whether it's dodgy government reports, dodgy journalism, bad behaviour by quacks, as well as bad behaviour by the pharmaceutical industry. And I don't think that I have any particular expertise. In fact, it goes without saying that I think you're probably all better at all of the things that you do in your sector. I think the one thing that I am maybe able to do is talk about these problems with the public and engage the public in helping us to fix these problems. Because I think there's often a very worrying tendency when there are challenges in a particular sector for people to knuckle down and engage in denialism. But there are genuine problems in the way that we research treatments and in the way that we synthesize evidence and communicate it to decision makers. And I think if we could fix those, then that would be to the greater good not just of patients but also of industry. It seems to me that we don't have a coherent infrastructure to support evidence-based practice in medicine. What we have instead is an ad hoc ecosystem of various different legacy projects that have arisen over time. And altogether, what this means is that we have inefficiencies at every single step of the way. If we had stepped back and designed what we thought evidence-based practice would look like, we certainly wouldn't have ended up with what we have today. A truly rational, coherent infrastructure for evidence-based practice would look a little bit like, well, firstly, we'd be much better at prioritising decisions about research that needs to be done. We would identify uncertainty whenever it exists. Having identified uncertainty, we would then prioritise those uncertainties. We would ensure that the questions we were asking were the questions that reflected patient need rather than other factors, whether it's conflicts of interest or just clinicians' own blinkered view that they know best. We would conduct fair tests to ensure that we resolve uncertainty, when in reality we know that we very frequently conduct trials which are flawed by design, often in such a way that they are unable to give a true answer about the genuine impact of a treatment in real-world patients. We would ensure that trial results never go missing in action, which, as some of you know, maybe is kind of one of my big preoccupations at the moment, setting up the All Trials campaign. The best currently available evidence shows that around half of all the trials that have been conducted on the treatments that we use today have not gone on to be published, and even if that's improving now, it makes very little difference because 85% of prescriptions in the UK are for treatments that came on the market more than 10 years ago. Then lastly, we would ensure that all the evidence that we have is synthesised together and disseminated to clinicians and patients, because they are both equal decision makers when we practice medicine at its best. And we would ensure that they have all of the evidence they need to make informed decisions. And lastly, we would ensure that we do audit to observe and assess the extent to which clinical practice reflects the best currently available evidence. And then lastly, we failed to do that. So what I'd like to do very, very rapidly, and I'm afraid I didn't know that I was talking on this subject, so forgive me if I peter out and stare blankly at the walls every now and then, is go through each of those steps, look at the extent to which we fall short and where there are opportunities for improvement. So firstly, the research prioritisation process. I think it's striking how much uncertainty there is in medicine and how bad we are at dealing with that. And that's partly a reflection, I think, of the extent to which doctors are not rational purchasers of treatments. In fact, we're a public procurement nightmare. There's 180,000 of us working in the UK, and we are in charge effectively of a £12 billion NHS prescribing budget, and we're pretty much behind closed doors, just dishing it out as and when. To put some numbers on this, there was a fantastic paper published in New England Journal 2011 which looked at every single new treatment approved from 2000 to 2010. And when you restricted these treatments only to those where they are new treatments for a condition where there already is a currently available effective treatment, still 30% of those drugs at the time of new approval had only been tested against a dummy placebo sugar tablet. Now, what's striking about that is this is not the clinical question that doctors need answered. When I'm deciding whether to use a treatment, I don't want to know if it's better than nothing. I want to know if it's better than what we already have. And yet we know that firstly, drugs routinely come to market without that evidence, and secondly, drugs are routinely prescribed by doctors without that evidence. Now, how does that happen? Well, it's partly because doctors are not demanding good quality comparative effectiveness data. It's partly because marketing departments of drug companies are actually very good at bamboozling us, persuading us to use treatments in the absence of good quality comparative effectiveness data. It's partly, I think, because many clinicians are not adequately aware of the need for good quality comparative effectiveness data. But it's also partly because there's nothing conspiratorial about this, but it's often not in people's interests to gather good quality comparative data on how well their drug matches up to the best currently available treatment. Because in economic terms, the better evidence you have on the relative effectiveness of your treatment, the more it tends towards being a commodity. And a commodity is a nightmare for people in industry. What people want is things which are hard to compare. That's why you'll never find two laptops with identical specifications, because as soon as something becomes absolutely comparable, the price tends to go down like any commodity would. Lastly, I think we failed to gather comparative effectiveness data because we've made the cost of information too high. Now, it's very easy to cast around and say, oh, it's all unnecessary bureaucratic red tape. With regulations, I don't think you measure the extent to which they're good or bad by weighing them. You don't say, well, we've got this many pages of regulation, therefore there's too much or there's too little. I think what we have with the regulatory framework around clinical trials is a lack of proportionality. And this is particularly relevant to trials which are addressing relevant clinical questions. And I'd like to illustrate this by talking about two different single cases. One is a trial that I would like to do, and the other is a trial which we have done. So firstly, the trial which we have done. It's extraordinary to me that statins, which are the single biggest, most widely prescribed class of drugs in the UK, one of the most widely prescribed classes of drugs ever, we still don't have good quality evidence with real-world outcomes to show which is the best currently available statin at normally prescribed doses for preventing real-world outcomes like heart attack, stroke, and death. We have surrogate outcome data comparing one statin against another to see which is best at lowering cholesterol, but as we all know, that's not enough. So the ALL-HAT trial was one of the big shockers of the past couple of decades of medicine. Big blood pressure pills, nobody knew which was best. They were both equally good at lowering blood pressure. Nobody knew which was best at preventing heart attack, stroke, and death. When we finally did a trial, and the ALL-HAT trial was an enormously expensive project, very, very difficult to do because it required following people up for a long time, because actually one of the really frustrating things about epidemiology and clinical trials, as I'm sure you'll know, is people take a really long time to die, right? And that's a drag, and it's something that we can't work around. You know, my wife worked on the 1946 birth cohort, and the thing about the 46 is they're just hitting 65. And nobody in the building is saying this because it's an ugly thought, but secretly I'm sure they're all going, hey, 65, we're going to start getting some deaths now. And we can look at childhood factors and see what... So people take a long time to die. That's why the ALL-HAT trial cost tens, I think over $100 million, just to follow up a few thousand people on blood pressure tablets. But terrifyingly what we found was two drugs with equal benefit on the surrogate outcome of lowering blood pressure were so radically different on the real-world outcome of preventing death that the trial had to be stopped early. Now with statins, we've got head-to-head evidence to show which is best at lowering cholesterol, and they're all pretty much of a muchness, but we don't have real-world outcome data showing which is better at preventing death. Now, to find that out, we would need to exploit routine data, and that's what we have set out to try and do. So we ran a trial using the General Practice Research Database, now renamed CPRD, although broadly similar data, it must be said. And CPRD is the routinely collected electronic health records from general practice of a couple of million patients. And the design of our study, stripped down to its absolute simplest, was as follows. We know that the difficulty with recruiting patients is patients and doctors both correctly ascertain that it's going to be a real drag being in a trial. It's going to be extra visits, it's going to be lots of paperwork, and we want to strip all of that out and see if we can run a trial, instead of £10,000 a patient, £100 a patient. So the first thing was, all the follow-up data, there are no special visits, no special blood tests, it's all routinely collected electronic health record data. So you never have to think about it ever again. Any cholesterols, just taken from routinely collected bloods if the doctor happened to order those. Same for LFTs, same for any hospital admissions, same for death. We get HES data, we get ONS data. So your follow-up comes entirely for free and forever. The randomization process is more interesting and much more challenging. So firstly, what we wanted to do was make sure that patients that were getting statins were exactly the same as patients who get statins. Now, that sounds like it's a tautology, but actually if you look at clinical trials, what you find is that trials are routinely done in patients who are ideal, perfect patients. They are less sick, they have fewer other medications, fewer other diagnoses, they don't have renal failure. They are, to all intents and purposes, almost entirely unrepresentative of the real-world population that actually get these treatments. There was a fantastic review looking at the external validity of the trials on asthma. So asthma is a very common condition, obviously, over 1 million patients in the UK with asthma, and what this piece of research did was they took a sample of just under 200 patients in general practice in the UK being treated according to the standard treatment guidelines for asthma, and then they said, okay, on average, what proportion of these patients who are actually being treated under these guidelines would be eligible to participate in the trials that created these guidelines? And the answer was, on average, 6%. 94% of the patients in the trials, 94% of the patients with asthma being treated according to these guidelines were ineligible to participate in those trials. I can tell you that when I see patients with depression in South London, not a single one of the patients that I've seen in the last couple of months could have been in any of the trials on depression in secondary care. They smoke dope, they drink alcohol, they drink coffee, which is often exclusion. I mean, you know, the exclusion criteria are ludicrous. The exclusion criteria for our statin trial was, did your doctor just try to give you a statin? Couldn't be any simpler. And at its most basic, what we aimed to do was, when a doctor sees a patient and tries to prescribe a statin, effectively a big red page comes up and says, wait, we don't know which of these two is the best. Press this big red button here to randomly assign your patient to one or the other, and you'll never have to think about it ever again. So what stopped us from being able to do that is really interesting. There was one barrier you'd expect and one that you wouldn't. How long have I got?
About 5 minutes.
Okay. So the barrier that you would have expected, and the one that you're all grown and sort of joyful to hear, ethics committees, with almost painful inevitability. Now there's a really interesting question here. So the ethics committees, to be clear, they basically said, look, you need pretty much a 20-minute long consent chat and a 7-page long form. Now, the interesting thing here is, to me, who is the more unethical doctor? The conversation you have as a physician working in general practice, handing over a statin, probably about 20 seconds long. Right? It probably goes roughly, for various different reasons. It looks like you are at a higher risk of having a heart attack or stroke. There are these tablets called statins. They've been taken by millions of people. They're fairly safe. Sometimes people get a bit of muscle ache. Sometimes people get odd liver function tests. If you have a problem, come back and see me, and we'll do a routine blood test in a couple of weeks. Have you got any questions? That's that. That's pretty much the end of the conversation. Maybe talk about diabetes if they've read the more recent evidence, but that's pretty much a brief conversation. The doctor who recognises that there is uncertainty about which treatment works best is actually, I think, the more ethical doctor, because they're being honest with their patients that we don't know which of the currently available statins is the best. They're trying to resolve uncertainty. But why should they have a conversation that lasts any longer than the conversation where somebody's just handing over a statin? To me, that makes no sense at all. If we were going to up the amount of time that somebody had to take explaining the risks of the treatment that's being offered, I think I would actually do that for the person who is recklessly allowing uncertainty to persist. Partly because we can put real numbers on this. So we modelled in CPRD what is the impact of not knowing what's the best currently available statin. Because these are so widely prescribed, these treatments, And they're so effective that actually if there was only a 2% difference in the effectiveness of the two most widely prescribed statins, and we failed to find that out, and we failed to act upon that information, then just a 2% difference, and that's a very conservative estimate, just a 2% difference with us failing to find out costs us around about 200 lives a year. So we're killing 200 people every year because we haven't bothered to do a head-to-head trial of the most widely prescribed treatment, not just in the United Kingdom, but probably in the world. Now there's an interesting thing about numbers like that. They were once described by a great public health doctor as deaths with the tears wiped off. And that's the funny thing about medical research. It's actually very difficult to remember that numbers on tables relate to real-world suffering and pain and death. That's a real empathy challenge. So I can still remember, I would probably never forget, what it was like to try and save somebody's life in A&E while they hosed blood all over my trousers with their mother standing next to me, begging and pleading for me to save their life, right? That's still a struggle, and it puts doctors out of medicine for life, those experiences. But when we hear that there are 200 people who died unnecessarily simply because we couldn't be bothered to be clueful about how we approach clinical trials, for some reason we don't feel that in our belly in the same way. And it's because of that failure of empathy, and also because of that simple intellectual failure, that we allow ourselves to have infrastructure around clinical trials that prevent us from addressing uncertainty. And I think doctors who fail to address uncertainty should be compelled to explain to their patients that they are allowing uncertainty to persist and that they are inflicting avoidable harm, not just on the population, but also on that patient. Because people who are on statins, long-term prevention, they're going to be around long enough to experience the benefits of trial data on those drugs. Now, secondly, I think there are implications here for how we deal with new treatments. Have I got 2 minutes?
2 minutes for Noble.
Right. So, exenatide, and this is selected entirely arbitrarily, and I don't mean to be mean to anybody who even makes exenatide or takes it. Exenatide is a new diabetes drug. It's been approved with surrogate data showing it's very good at lowering blood sugar, but no data showing that it's any better at reducing real-world outcomes like death, and that's all we care about with diabetes. We know very well from the experience of rosiglitazone, the diabetes drug Avandia, that treatments which are very good at lowering your blood pressure, your blood sugar, can actually increase your chances of having cardiac problems. So what we care about are the long-term outcomes. So firstly, it's surprising to me that anybody is willing to use exenatide at all when it only has surrogate outcome data. But secondly, it surprises me that we've tolerated the arrival of treatments on the market without good quality evidence of how well they work. And here's how we could resolve that. NICE has 3 options. NICE can say, yes, this treatment's great, let's use it. They can say, no, we don't think the evidence is good enough, let's not use it. And the third option, which they almost never use, which is for only in research, OIR. On the very rare occasions that it is used, it's used to do some rubbish survey where the people go and ask patients, did you like being on this drug? And they say, yes, we thought it was fabulous. But we could say, look, exenatide, new diabetes drug, we don't know how well it works. It's only available on the NHS in the context of a randomised trial. If you want to prescribe this treatment, then it has to be in the context of an RCT. And that's the only thing that will reduce the period of uncertainty where we don't know its true benefits and increase the benefits for patients. I think that not only should we be trying to reduce the amount of red tape around clinical trials in the small isolated instance that we come across that we'll notice on a day-to-day basis, I think we should be going further. I think we should be looking to make the British National Health Service, but also medical service providers around the world, into institutions that test, learn and adapt wherever there is uncertainty without thinking that that is an exceptional part of clinical care. I think randomisation, after identifying uncertainty, should be the norm in clinical practice. It shouldn't be the exception. And I think that's where we should all be looking towards.